Thank you very much. It's great to be back here. I think I've come to all of the Asian Association meetings for the last, I don't know how many meetings. It's always great to come here to see old friends and to meet new friends. It's an honor to be giving a plenary lecture. So today I just want to talk about the technical and technological advances in thyroid surgery. It's sort of a fun talk, and I hope you all enjoy it. It will be a bit of a whirlwind review of what we know about thyroid techniques, thyroid surgery techniques and technology. So yesterday we heard from Ratan that the Arabic surgeon Al-Kazim was the first documented operation, but I actually find it in the Chinese textbook. The Chinese beat the Arabs by 15 years in doing thyroidectomy. Now, of course, the one that's most well known is from the school of Salerno, Roger Bugatti. And this is just a description from the textbook about how they did a thyroidectomy. They put a hot iron right through the goiter, put a suture through it, and start tying it like a C-top. Those of you who do anal rectal surgery would know we use C-top there for anal fistulas, and it can be quite painful. And then this way, slowly cut through the thyroid, and that's how they did the operation in the old days. And this technique, I think, was in use for quite a long time, from the Middle Ages until basically to 18th, 19th century. Now, somewhere between then and now, this is in my operating room. I pull out some instruments, and here are the names. There's Coker, there's a Halstead hemostat, there's a Mayo clamp, there's a cryo, there's a Leahy retractor, and this is how I do my operations. Now, I found this wonderful article that talk about the Magnificent Seven of modern thyroid surgery. Now remember, all of those instruments are also instruments that we use just for regular general surgery operations. They're not specifically for thyroid operations. And yet, they're named after some of the giants. So these are the Magnificent Seven of modern thyroid surgery. Now, the earliest one is Theodore Billroth. Now, Billroth actually had a terrible result early on. He had 40% mortality rate. Now, nowadays, if you have 40% mortality rate in your hospital, the QI committee will for sure come after you, and you have to stop doing the operation. And he actually did, because he had 8 patients die, and seven of them died from sepsis. Now, keep in mind, this is early on, so this is before the days when antisepsis and asepsis technique were being used. He subsequently went back to thyroid operation and was able to achieve the mortality instead of 40% to below 10%, and actually continued to do thyroid operation, and subsequently taught Micklitz and Wolfer to also modify the technique. And so he sort of started the modern thyroid surgery. Now, the one that we all know the best is Theodore Coker. Now, you all know that Coker won the Nobel Prize in 1909. And one of the amazing things, if you think about it, is this. This was the day, these were the days that they did not even know that thyroid hormone exists. And if you look at the picture on the right there, Coker basically realized he saw a patient that he operated on at age 11. And 8 years later, that patient was hypothyroid. Now, he did not know that the patient was hypothyroid, but he knew that something was wrong because he took out the whole thyroid. And he called the condition cachexia struma priva. You can compare the patient who was hypothyroid with the younger sister, who 8 years later became a full-grown woman, and yet the one that's hypothyroid looked terrible. So with this, he actually went from total thyroidectomy back to subtotal thyroidectomy. He was one of the first to do total thyroidectomy, and his operation was so good that he discovered hypothyroidism. Whereas Theodore Coker did not see hypothyroidism because he was much faster, left a lot of thyroid behind. But Bill Roth had no hypothyroidism, but lots and lots of hypoparathyroidism. Now, the next famous thyroid surgeon is William Stewart Halsted. Now, Halsted is the one that made this quote that all of us thyroid surgeons like to say is a thyroid operation is the triumph, the supreme triumph of the surgeon's art. If you're a good surgeon, you know how to do a thyroid without killing your patients. Another thing that many people do not know is that he was really the special person in describing parathyroids and how to preserve parathyroid. This is the paper that he wrote with the Californian, actually, named Evans. Described the parathyroid vascular anatomy as a cherry on a stem. And that's how I teach my residents. Think about your thyroid gland. It's a cherry on a stem. You don't just preserve the cherry. You need to make sure that the stem is preserved so that there's blood supply to it. And so that's all stem. Now the next three, Charles Mayo, George Quayle, and Frank Leahy, these were giants in their days, and they all became famous because of their ability to do good thyroid operation. And actually, Frank Leahy was one that was really the first to emphasize that you need to see the recurrent laryngeal nerve well to preserve it. And guess what? All three of these went on to found clinics, the Mayo Clinic, the Cleveland Clinic, and the Leahy Clinic. So all these named famous clinics in the United States came from surgeons that are thyroid surgeons. Thomas Dunhill is actually my favorite of all this group. And of course, he's Australian from Melbourne. Yeah, there we go, Jimmy. So I think we're going to be in Melbourne 2 years from now, so I can talk about the story again. He was a very famous Australian thyroid surgeon, and he was one that was so brave that would operate on these patients with terrible heart and huge goiters and etc. But he is known to us for his Dunhill procedure, which is unilateral lobectomy and a subtotal lobectomy on the contralateral side. He was so good that he went to Britain and he became the surgeon to the royal household, to the kings and queens and princes and the princes of Great Britain. But his most famous operation was not a thyroid operation. His most famous operation was an inguinal hernia that he did on Winston Churchill. And this repair actually lasted until Churchill's death. And however, the interesting thing is that they were general surgeons that criticized that as a general surgeon, Dunhill was too old and too slow. That his inguinal hernia operation took 2 hours. In those days, apparently it took only 20 minutes. And if you look at the last line there, that his surgeon might not have been the best choice, since Dunhill this time was 81, and he was a thyroid surgeon. So, but those of you that do hernia repair will probably know that when a thyroid surgeon do a hernia repair, it will be slower, but you would not lose any blood, not like the regular general surgeons. So if you look at this, in the late 19th century, the problem that the surgeons were trying to deal with were sepsis with infection, early on, and then bleeding was next. Then in the 20th century, as these giants of thyroid surgeon begin to perfect the technique, the problems were hypothyroidism, recurrent nerve injury, hypoparathyroidism. And they still plague us nowadays, although not as much as it was before. And we'll talk a little bit about now into earliest 21st century, we begin to worry about cosmetics of the neck, about scars. Okay. Now let's talk about hemostasis and bleeding. Currently, the overall bleeding risk for thyroid operation should be less than 1% in terms of hematoma. And I put down a list there of what are the kinds of things that tend to increase the risk of bleeding. This is a very good article with a review from Dr. Campbell. Now we all know Bovie, but some of you may not know that Bovie invented Bovie, which is a model called polar cautery, working with Harvey Cushing. And Harvey Cushing actually is also an endocrine surgeon, except he operated the pituitary, so somehow we don't count him as an endocrine surgeon. And Bovie, during the development of his Bovie, actually electrocuted Cushing's. And early on, he developed this at Hopkins. But those of you that are old enough that the East Coast people did not like to use monopolar cautery at all. I remember talking to Norman Thompson once, and I showed him a videotape of my thyroid operation, and he was horrified that I used monopolar cautery and I used it so close to the nerve. And so people in the East Coast used to call the Bovie the West Coast barbecue. And he liked it so much, he sold the patent for only $1 so that everybody can use it. And nowadays, most of us, monopolar cautery, we call Bovie, and it's a very standard thing that we use. Now currently, some of the newer technology, new energy sources that you heard about in some of the talks here that begin to allow us to do the operation. When I was a junior resident learning how to do thyroid operation, it was not uncommon for me to do 200 silk ties in a thyroid case. Now we do 0. We do all these operations almost always with energy sources. Now let's go into nerves. The recurrent laryngeal nerve, this is Galen when he demonstrate the recurrent laryngeal nerve by having a squeaking pig. This is in Rome, and then he would go in and stick his hand in and cut the nerve, and the pig would stop squeaking, and it's sort of like a magic show for this. But in those days, they actually thought, both Galen and subsequently Leonardo, they thought maybe the nerve worked as a pulley. That's why you have a recurrent nerve like a pulley, but obviously they did not know about electrophysiology. The other nerve is Amelita-Galli-Curci nerve, and actually Radhan and I were talking about this yesterday. It was probably a mistake that we attributed the fact that Galli-Curci could not sing mezzo-soprano anymore in her 50s due to the operation. Probably just because she was getting old, and when you get older, you just cannot sing that kind of high note anymore. But it makes a good story, and so we call it the Amelita-Galli-Curci nerve. Now, we have new technologies to evaluate these nerves. Most of you probably use various types of nerve monitoring that you can do. And now keep in mind, however, there's really very little level 1 evidence for the use of recurrent laryngeal nerve monitoring to prevent nerve injury. And today, this is still the biggest series. This is from Drelle, and this is 14 years old now. They review all the German, it is a retrospective review of German surgeons. And in the end, what they found is what Frank Leahy taught us, that the most important thing is to identify the nerve. If you don't identify the nerve, your rate is 40% higher. But if you use a nerve monitoring, it actually makes no difference in this particular series. Now, there are other reasons to use it besides trying to protect the nerve, and probably in a subgroup of patients, nerve monitoring is quite useful. Now, to tell the truth, I actually use it for all my cases. Some of it is for teaching. The only good prospective randomized study is a study from Basinski, where he found that the temporary nerve injury rate in a complex operation, there appeared to be a statistically significant difference between 5% and 2.7%, but this is only for temporary injury. Okay? So this is probably the only study that has good prospective randomized study. Now, other things, however, we discover and learn or relearn from use of nerve monitoring. So this is a thing I call the Serpell's rule. So Jonathan Serpell described that if you see bifurcated nerves in your recurrent laryngeal nerve, the anterior nerve is the important motor nerve. So it's good to know that, and they're actually quite frequent. You can see how often you can see bifurcated nerve. It's always the anterior one that's important. Now, we just heard a little bit about non-recurrent laryngeal nerve. Again, you can find these with nerve monitoring. But nowadays, we know even better than that. We know the reason you have non-recurrent nerve on the right side is because of vascular anomaly. The non-recurrent nerve on the right side is almost always associated with an abnormal origin of the right subclavian artery, because that's the nerve, that's the vessel that your nerve hook around. So, and nowadays, frequently, people get CT scans or preoperative ultrasound. So, most of our non-recurrent laryngeal nerve that we see currently, we know it before we go to the operating room. So, if you have a CT scan and you say, gee, the right subclavian artery comes from the wrong place, that is a patient that you will see a non-recurrent recurrent nerve on the right side. So, keep that in mind. So nowadays, again, the guidelines basically say that we really should identify the nerve. If we want to use nerve monitoring, that's good. But the data is not that clean. So this is a country data that's published by Mary Hahn, who was in Alabama before, but she's now in Stanford as a chair there. And they did a review of big databases, and they actually found that use of neural monitoring is associated with increased vocal cord paralysis. Now, all of us would know that this is really a patient selection issue, but again, there's really no good proof that using nerve monitoring improve the vocal cord paralysis. Many of us now also use continuous nerve monitoring. This is just one of the drawings. I'll show you that with traction, by stretching the nerve, compression the nerve, you can see in real time that you're doing something bad to the nerve, so you can stop. So it's a very interesting technique, very instructional technique, learning how you'll be operating and how you may be affecting the nerve. But not everybody uses it in the United States. In fact, there's been quite a bit of concern. This is a paper from Dave Terrace, who described some injury to the vagus nerve when you do these continuous nerve monitoring. So there's still quite a bit of debate as to whether or not one should use continuous nerve monitoring. The UCSF, of the 5 people there, I'm the only one that do continuous nerve monitoring, and I only use it for big goiters because there I cannot get to the recurrent nerve until very late. So it's nice to have the vagus nerve monitoring, and so that I can tell before I get to the recurrent laryngeal nerve, I know that things are okay. Other technology, actually this is one of the newer things that is very commonly used now in the United States by the endocrine surgeons. I don't know about in Asia, although this comes from Asia. It was initially described in Taiwan and then subsequently popularized by people from Hong Kong, is to use ultrasound to look at your vocal cord function. So for those of you that don't like to do laryngoscopy for evaluating your vocal cord, you can actually use ultrasound. And it works quite well. We do it in the clinic routinely. Although if we see something abnormal, we almost always confirm it with the laryngoscopy. Now we talk quite a bit about parathyroid and how to preserve it, and the cherry on the stem and all that. So currently, the 2 newest techniques that's beginning to be on the market now of identifying and to help preserve parathyroid gland is to use a near-infrared autofluorescence. As it turns out, your parathyroid gland has different composition such that if you shine a laser light of a certain frequency on it, it would re-emit near-infrared at a particular spectrum. And so you can put a scope in there and you can tell what your parathyroid is. You would light up. And I think the machine is called flow beam. So you use it without any kind of contrast. Just look at it and you can see the parathyroid gland. You can identify the parathyroid. The one on the right is ICG, and that's a different technique. In that technique, you inject ICG dye. Now, those of you that do general surgery, many general surgeons are using this for gallbladder operation, where they can identify the gallbladder vessel, etc. And you use the same technique, the same scope, is again, you inject ICG and you get fluorescent. The 2 differences is that the ICG technique, you can actually see the blood vessel. You can see the stem of the cherry. Also, if you devascularize that, the parathyroid or the cherry will no longer light up. So there are different kinds of technique. One is to identify whether or not it is a parathyroid. The other one is to identify whether or not the tissue that you see is vascularized. So some people are using the ICG technique to decide whether or not to auto transplant, for example. We are beginning to use a near-infrared fluorescent on the specimen to just make sure that when we look at the specimen, there's not a little bright dot there that we need to take out and auto transplant it into the patient. So keep an eye on these techniques. They're going to be used frequently. Many of us also use endothyroidectomy intraoptic PTH. And it's still relatively controversial, but the majority opinion is that at the end of the case, or maybe a few hours after the case, if you check a PTH in the thyroid case, and the PTH is low enough, then that patient is at much higher risk for transient or permanent hypoparathyroidism. And in our center, our upper normal is 65, and if we see an end of case PTH lower than 10, we worry a little bit more about those patients. For example, we will give those patients calcitriol, whereas all the other patients would just give them calcium. So it's a reasonable thing to do. It's not an absolute predictor, but you can get a sense whether or not the patient is going to be at high risk. Now I have 1 minute to tell you a little bit about minimally invasive thyroidectomy, and now I'm just going to go through this really fast. The most commonly used one in Europe is a MEVAP technique. This is the Powell-Mickley technique, small 1 centimeter incision, go in with the scope. It's a very easy technique to learn. The biggest problem is that it requires 3 surgeons, so it makes it hard to use in practice. So we don't do it anymore, but it's a very good technique to learn. Other endoscopic technique, I think that the Japanese surgeon initially develops, but this is used quite often in Asia. If you go to places like Vietnam, like Thailand, this is used quite commonly. Using scope through the breast and through the axilla, this is more popular in Korea and in China. In fact, in China, this is probably the most popular technique. It's called the Baba operation. And this is Woon-Young Chung's procedure. I think they've done probably 5,000 of these now from Korea. This is using a gasless lifting technique from the axilla, use a robot, and it's a robot-assisted transaxillary technique. Now, in the United States, people have tried this, but in the U.S., this is no longer done by more than 1 or 2 centers. And then this is Dave Terrace. Does something called the facelift technique. So he makes an incision in the back and you can lift up the... So all of these are to avoid incision in the neck, and they have different people that are trying out these things. However, there have been some robot-associated problems in thyroidectomy in the United States, and so in about 2011, the FDA, the Intuitive company tell you that you cannot use thyroid for, you cannot use a robot for thyroid operation anymore. And in fact, you can see the dip there in terms of number of cases since that happened. So the use of robot for thyroid operation in the United States has not really recovered, and it's really in very few centers that's being done. So there are other more interesting technique. This is through the mouth. This is the real nose operation. Those of you that do endoscopic, laparoscopic operations, the best nose operations are thyroid operations. This is the original German technique, floor the mouth, very painful, lots of complications. Very few people do this now, except in southern China, quite a few people are still using this. This is the original transoral vestibular technique from Japan. The trouble with this, if you look at that cut there, they cut the mental nerve when they do this. It's a lifting technique, so this is also no longer used. But this technique has been modified by Ankun Anuwan, who is in Bangkok. Now, Ankun now has done about 800 of these cases, using 3 incisions from the mouth just in front of the teeth. And if you look at that, you say, oh my God, for sure you're going to get infection, you're going to get all kinds of trouble. But if you look at this is the biggest series that's published, but he's up to about 800. There have been no infection. So one of the biggest fear of doing transoral is infection, but there's been no infections. So Now, we do all of these mainly to avoid a scar, like this is the president of Argentina and showing off her terrible looking scar, but most of it is actually the patient has reasonable sized scar. So it's still, and this is the patient 13 years later, you can't tell there's a scar in the neck. So I think it's still, once you have to think about whether or not that we should be doing these operations, but if we do, we're really doing it for the cosmetic. And one last thing I want to tell you is an operation, we call it Pokemon Go. Now, those of you not in the United States probably don't know what Pokemon Go is. The children will take the iPhone, and it's a virtual reality. They will see the background, which is real, but they will see these Pokemon characters in there. So the Pokemon Go operation is that you do CT scans or other scans of the structures that you want to see. Then you superimpose it on the patient. And so if you put on a pair of goggles or put on it with a scope, the surgeon can actually see through the patient and see all the structures in there and do thyroidectomy and parathyroidectomies. So, last slides. Technical and technological advances in thyroid surgery, although basic thyroid operation has not changed in the last 100 years, the technical and technological advances have improved our ability to prevent complication and modify our approach to thyroid glands. Thank you very much.